One thing you ought to know is this lecture is not like my typical lecture. I like data-driven lectures. I like to advise people based on data, and I will tell you that there are very little data out here about electronic medical records, particularly electronic medical records in OB. So most of this is going to be an experience lecture, all right? We do have an electronic medical record, and so I'm going to try to just cover some things that I think you ought to think about when considering the electronic medical record on your labor and delivery unit. So I have no disclosures relative to this topic other than to tell you that I'm not an IT expert, so don't ask me any IT questions. I'm not an EMR expert, so don't ask me too many difficult EMR questions. I'm not a billing and compliance expert, all right, but I am a frequent user of the electronic medical record, particularly on our labor and delivery unit. So if you can't read the bottom of this comic, it says, this is where the idea for the new EHR, electronic health record, starts getting a little complicated, right, on the right side. So don't ask me any questions about the right side. I only understand the left side of this comic. All right, so we're going to talk about special challenges relative to the use of the EMR on the labor and delivery unit, and then just discuss some of the issues that you need to be aware of when you're using an electronic health record for anesthesia documentation on the labor and delivery unit. So we're going to do a little old-fashioned audience response here to keep you awake. So use your hands. Do you have an AIMS, an anesthesia information management system, or an anesthesia EMR in your general operating rooms? Okay, so raise your hands. What are we going to say, 60% or something like that? Okay, all right, keep your hands up, the people who have their hands up. The next question is, how many of those of you that have this in the main operating room also have it on your labor and delivery unit? So a few hands went down, all right? So there are some people that are electronic across the board, some who are half and half, and others who don't have an electronic anesthesia record yet. All right. I looked for some data out there. These are the only data in this talk. These are now old, early 2010. A survey was sent around. The response rate was not great. It was only about 12%. And in early 2010, about 24% of the respondents had an electronic EMR, anesthesia EMR, in their hospital. Didn't ask specifically labor and delivery, just said for the general operating rooms. And you can see from the graph on the right side that the bigger the hospital, the more likely the hospital was to have had an electronic record in the operating room. This is published this month in ANA, and this was a survey that was sent to all academic programs in the United States. So we have 130 residency programs in the United States right now. There was a 100% response rate. The bell-shaped curve on the bottom is what it looks like if you introduce any new technology. Okay, it takes a couple of years to get started. Then there's a time where there's sort of the maximum recruitment, and then it kind of lags off, right? And there's a few laggards. And if you look at the red curve, that's the cumulative curve, all right? And you can see the dotted line. That is the predicted number of academic anesthesia programs that will have an electronic anesthesia record at the end of 2014. I think the number is 74% on there, 75%, all right? So about 75% of programs by the end of this year are expected to have an electronic medical record. You can see that this kind of approaches the right side of the bell-shaped curve, and they've labeled the right side of the bell-shaped curve laggards, okay? So if you're an academic program and you don't have a record by the end of this year, you're a laggard, according to this paper. All right, so what are some key functions, features and functionalities? And again, this is not going to be a lecture on the EMR per se. You don't really have a choice. If you don't have it, it is coming to you, okay? It's just a matter of timing, right? You might retire before then, but at some point, all of us will have electronic health records and electronic anesthesia records in our hospitals. So the key features and functionalities are obviously an interface with our physiologic monitors, anesthesia and analgesia, that's what we're talking about today, documentation. They're used for billing and charge capture, hopefully for quality assurance, They can be used to hopefully provide safer anesthesia by giving us alerts and reminders about the things that we should be doing. Decision support, for example, if you have a cardiac arrest on the labor and delivery unit, it would be ideal to have an electronic system that could help you focus on causes and actions we should take for a cardiac arrest of a obstetric patient compared to a patient in the regular OR, for example. And one of the ways to do this is by using case templates, and I'll discuss them in a minute. Other functionalities include reporting and compliance audits. Some people use the records for the system for patient tracking, all right, where the patients are they in the recovery room, the operating room, the pre-op holding area, the operating room, the recovery room, et cetera. And optimally, you're using a system that's configurable, all right, to your particular institution and also where you're working, okay? So we're going to discuss in a minute that using the anesthetic record on the labor and delivery unit is different than using it in the operating room. And then there's the whole question of, is it integrated with your institutional EMR? And I think the answer is optimally yes, but they all aren't at this point. Advantages of using an EMR, I think we all know them. There's better communication. There's integration with the general EMR. Why is this important? Well, you know, in the past we had a paper record that, maybe it's not the past for some of you, it's still a present, but we have a paper record that no one else can read. All right, non-anesthesia providers have no clue. They cannot look at anesthesia record, for example, and tell when the epidural morphine was given, right? Can your nurse look at a paper record that you've generated and tell when you gave the morphine? Our nurses cannot. The rest of the institution cannot tell that we gave ondansetron at this particular time or we gave an opioid, all right? There's no way that our paper record is integrated with the general record, even if it's a paper record, all right, in the general electronic, general medical record. So I think major safety advantage with electronic records is all of the things that we do which potentially affect the patient are integrated into the general EMR and everybody else can figure it out, all right, not just an anesthesia provider. This includes medications, which I just mentioned, fluids, right, the fluids we give in the operating room, the blood loss, that kind of thing. All of that gets integrated into the general record so everybody can see it without having to decipher a handwritten anesthesia record. So it does improve communication. Obviously improves legibility and accuracy. It makes it much easier for us to access old records. So if a patient comes in and says, I had a difficult time with my last anesthetic, they punctured my back 4 times, you can look at the old anesthetic record and figure that it really was only once and the patient was thinking of something else. And then finally, hopefully, we can use it for research. This is a goal of people who work in academic institutions. I'm sad to say that it's not as easy as we'd all like it to be, but it is out there, and it is a potential use of our electronic records. Okay. Disadvantages, well, it's slower, all right? I have to tell you, it is slower. The slowest part is actually logging in. I'm hoping that in the next 5 years that we will figure out ways to log in faster, but at least in my hospital, the way you have to log in is you have to bring the computer up and, you know, type in the password and then the hourglass goes around, right? And then once you get into the whole thing, you got to log into the anesthesia EMR part of it, so you got to do it again, okay? It really is slower, unfortunately. And when it crashes, it's kind of ugly. Okay, because, you know, there's a backup system to paper, it's called paper. And there is no backup system to an electronic medical record that works. So it's quite painful when the system crashes for everybody in the institution. All right, so I briefly alluded to the fact that currently there are 2 major types of anesthesia EMRs. One is called the fully integrated anesthesia EMR. So this is when the record that we're documenting on is an integral part of the institutional EMR, all right? And then there's what's called best of breed, which is an anesthesia EMR that was developed just for anesthesia. All right, and some of our institutions have those too. So there are disadvantages and advantages to both, obviously. That's true of everything in life. The best of breed are nice because it was developed by anesthesiologists, all right? They know what we do in the operating room. It's very intuitive for anesthesia providers. It's pretty easy to go from paper to electronic because it's so intuitive, all right? It does what we want it to do. It does the audits that we think are important. The problem is that many of these do not talk to the hospital EMR, all right? And again, I think that is a major disadvantage of these systems. So there are both out there right now. I suspect eventually we are going to move to all fully integrated systems, but right now hospitals have both types of systems, all right? And then remember that even if you work with a fully integrated system, that fully integrated system was developed for a general operating room. Nobody was thinking of a labor and delivery unit when they developed electronic anesthesia records. I'm pretty convinced of this. I mean, I don't know it for a fact, but I think that nobody thought that we would, eventually have to use these systems on our labor and delivery units, and the patient flow and the anesthesia flow and everything else is different on a labor and delivery unit than it is in a general operating room. So this forces us to, and I'm going to talk about this in the next couple of minutes, invent a few workarounds, all right? That's a polite way of saying it, so that we can use these systems in our operating rooms and make them work. In our labor and delivery units and make them work. All right, so the practical considerations, I'm not going to talk about this because I really don't know a whole lot about it. Hardware, got to have hardware and a workstation, and then there's obviously software and the interfaces. I thought I'd show you a few pictures of our labor and delivery rooms at Prentice Women's Hospital at Northwestern and how we have them set up. So this is the head of the bed, and on the left side is where the nurses hang out, all right? That's the nurses monitor over there on the left side, and on the right side, over there in the corner, is the anesthesia providers hang out. All right, if we have a close-up of the nurses' work area or workstation, we've got the fetal monitor there circled in purple on the bottom, okay? And then you notice that the screen on that fetal monitor is about this big, all right? And if you're the anesthesia provider standing on the opposite side of the bed, you can't see it. So we actually have a slave monitor that's mounted on the top of the cart right there. That is just a slave of the monitor down below, the screen down below, so that we can observe the maternal blood pressure, heart rate, pulse oximeter, fetal heart rate, all that stuff without having to strain our eyes or our back by bending over the bed. And that's the nurse's monitor and keyboard right there, and underneath here in the corner, down here is the nurse's computer, all right? Then on the other side of the bed, we have the anesthesia workstation, all right? So here's our computer, our monitor and keyboard, and our computer's mounted on the wall right there. Here's our anesthesia cart, here's the pump, all right? There is wiring that we can't see behind this headboard right here. They're all supposed to be connected, and the operative word here is supposed to be connected, okay? Because I will tell you right now, it works less than 100% of the time. All right. So our particular record is a fully integrated system. I am not going to tell you what system. You can ask me in the question and answer period afterwards. But we have what are called, and I think all of the systems have things like this, macros, all right, that are specific to different types of anesthesia procedures. So we have 6 different macros. I was going to delete the bottom one after this weekend's discussion because I didn't really want you to know that we do blood patches because we never get wet taps. But I'm being honest here. Okay, so we have 6 different macros. Obviously, on the labor floor, we use the top one, neuraxial labor analgesia, and in the operating room, we've got the next 4, cesarean delivery under spinal, CSE, epidural, and then general. And then the bottom one, hopefully we don't use too often, which is the blood patch macro. And here's just a picture of the screen, so we can click on one of these buttons and bring up the macro. And the macro has a list of things that we need to do or drugs that we commonly use for each one of these procedures. We, as much as possible, use actions that we use in the general operating room. All right, so if we do airway management in our obstetric operating rooms, it's the same airway management action that we use in the general operating room, but we have a couple of actions that are specific to labor and delivery that no one else in the whole institution does, and we develop those with our EMR people. So there's obviously one for OB neuraxial procedures. Even the pain people who do neuraxial procedures don't do it the same way. It's done on labor and delivery and use different drugs, so there is a specific macro just for OB. We have a macro for what we call assessments. So when the nurse observes non-reassuring fetal status, that basically means a fetal heart rate pattern that she's worried about. Usually that's it. Sometimes there's hypotension involved, maternal hypotension, whatever. She needs a physician or an anesthesia or obstetric provider in the room. She hits a button on the wall, and we get a page or a phone call that says there is an OB assessment. So we have a specific action for assessments that I'll show you in a minute. There is a sign-out transfer of care that's specific to OB anesthesia, and then our billing compliance form is slightly different than the one for the general operating room. This is a picture of our medical record. I won't go into details here. This is just the central neuraxial block action, so you can see that we've sort of spelled out everything that you would normally document by hand, right? You would put this in a note if you were doing neuraxial analgesia. Some of these green boxes are pre-populated, all right? So for example, for the prep, we always use ChloraPrep, all right? And we always sterilely prep and drape, so those are pre-populated. All right, monitor, and we always use a blood pressure and a pulse oximeter. Ultrasound guided, yes and no, that's not pre-populated because that may change among patients. Our approach may change, could be midline or paramedian, so that's not pre-populated. So we try to pre-populate the things that we do 100% of the time or close to 100% of the time. Makes for fewer buttons to push when we're documenting. This is the OB assessment I told you about, all right? So the reason for the assessment, fetal heart rate changes, what the interventions are, such as repositioning the patient, giving an IV bolus, turning off the oxytocin, all of those get documented when we're called for an assessment. We have a special one for transfer of care. Again, I'm not going to go into all the details, but it reminds you of the things that we need to document before the patient leaves our care, including that the sensory level's regressing, that we've pulled out the epidural catheter and the tip is intact. All right? And then something that we spent a lot of time on, and you're going to have to spend a lot of time on this, I think, is billing compliance. All right, how do you document adequately on the analgesia record so that the billing compliance people will be happy? And what we struggled with is that we have multiple attending anesthesiologists usually taking care of one patient. All right. And in the general operating room, it's usually only one, maybe two anesthesiologists. And every time we transfer care, the new anesthesia provider has to document all of the things that make us billing compliant. And I forgot to put a list up here, all right? Well, in our labor and delivery unit, I sometimes come out in the morning and there are 25 epidurals in, all right? And I don't really want to go through 25 charts and document billing compliance on 25 patients. I guess if I had to, I'd have to, but we talked them into it, okay, I'll put it that way. After lots of discussion, we talked our compliance people into including this statement, all right, that says the signatories on this record were available and, what does it say, responsible for all aspects of analgesia care, including, and you can read it in the post-op, it has all the things that we need to be compliant with, right, in that single statement. And we don't do it individually every time we sign on to the record. And our legal people signed off on it. So far, we have not been audited and suffered any adverse consequences because of it. But this was our compromise, and it is a little bit of a compromise in terms of billing compliance. So I just want to put that out there. I think different people deal with it differently, but it's something that we spent a lot of time talking about and had a lot of discussion about our billing compliance. All right, what are some practical considerations relative to L&D? Well, one of them is scheduling. So I know all the systems are different, but in operating rooms, usually the scheduling system is tied up with the EMR, all right? And it's made out ahead of time, and we know when 95% of the cases are going to occur and in what room they're going to go into, all right? So when you walk into the operating room in the morning and you open up our EMR, it's got already a list of cases that are scheduled for that room. Very easy to find your patient, all right? Well, on the labor and delivery unit, in my institution, we take care of about 40 or 50 laboring patients a day, and we don't know what room they're going to go into until 10 seconds before they walk into the room. All right, so then we have to pull up a list of 40 or 50 patients to find our patient who's in that particular room, and particularly when you're in a hurry or in an emergency, it's a little hard to go through 40 or 50 patients and find the right record. I'm not going to go into details about how we solved that problem. I just want to make you aware that no one thought of this when they integrated the scheduling system into the EMR, that it would be ever used in an environment where you actually don't know what room the patient's going to be into until 10 seconds before you start taking care of the patient. All right, another issue that we have to deal with on the labor and delivery unit is that we have multiple patient visits between the start and the stop time, right? So in an operating room, you take care of the patient from start to stop, and the anesthesia provider is there 100% of the time. This is not true of a labor record, so how do we deal with that? All right. I've seen different systems. I actually heard of one system last week that I was appalled by. I hope you're not from that hospital. But I heard last week that somebody who has an electronic EMR, they document the initiation of epidural analgesia in their electronic EMR, and then all the other doses or visits are documented in the progress notes. I'm thinking, that doesn't sound very safe to me. I mean, how do you know? You can't look at the record and figure out what was done at the beginning unless you open up both the anesthesia record and a progress note. It made no sense to me. Anyways, but this is an issue, right? I mean, back in the old days, or our old days, on the paper record, we do a squiggly line and start at a new time. Okay, can't draw a squiggly line on the EMR. Our solution was it just scrolls. Okay, we suspend the record so that no vital signs are flowing in. It's quite clear that there was no anesthesia provider in the room, but the record is pages long. Okay, and it's pretty easy. If you want to get to the end, you know, you go to the end button, but if you want to find something in the middle, you just have to scroll. It's a workaround. Controlled substance reconciliation, we do that right in our record. It's actually fairly straightforward. We struggled with what we are going to do when we convert labor analgesia to cesarean delivery anesthesia. Should it be the same record? All right, should it be a different record? I think, again, there are different solutions to this problem depending upon how you do things in your institution. This was a long conversation with our billing people, all right, because they're the ones that it actually makes a difference for. How are they going to use the anesthesia record to generate a bill? And if we have labor analgesia and cesarean delivery anesthesia on the same record, how does that mess up or influence their billing? So that was a long discussion. PCEA documentation, currently we have to do it manually. Ideally, we would have a pump that dumps in all of the PCEA information electronically, and that is coming, but we don't have it yet. Another thing I think you have to really seriously talk about in your institution is IT support 24/7. Now somehow, I don't know how they did this, but the hospital forgot that anesthesia units run 24/7, okay? We are there all night, and we use the EMR all night, all right? They had this system where they wanted us to call the help desk, and there was one help guy at the end of the desk who would answer the phone after it rang for 5 minutes because it was the only guy in the whole institution, or gal. And they didn't know anything about our anesthesia EMR. It was a very big hassle, and particularly at the beginning when there's a lot of issues, you can't have that kind of support. So I would say when you go to your electronic medical record, you really have to put your foot down and make sure that there is support for you 24/7 if you're working in your labor and delivery units 24/7. I'll show you in a minute what we've finally come up with, but it was a little late and quite frustrating until we got better support. All right, so L&D specific decision support, I briefly mentioned that before. And then the other thing we deal with is what do we do in a crash, okay? Because in a crash, we cannot type in our password. It doesn't work fast enough. So how do we open up the record? And in a crash, all right, I would like to know what the patient's airway is like, or review the airway, review the allergies before I crash the woman to the back. And I can't open up a record to do that. I have too many other things to do. So we have resorted to paper for that particular problem still. We actually print out our preoperative assessment and leave it at the patient's bedside so that in an emergency, we still have a piece of paper. I'd love to hear other ideas on how to deal with that situation, but we have not found a better alternative up until this point. All right, here is our final IT solution to IT support. We now have an icon on our desktop. That's this little buoy, life buoy right here. If we double click on that icon, it opens up this window, and we can put in our problem and push this button, submit, and it automatically pages the IT tech who might be at home sleeping, all right, but they now have to answer the page. I think my name is probably Mud among them, because when I'm on call at night, I page them probably a couple times a night with IT problems, EMR problems. But we have finally convinced the hospital that this is the level of support that we need in order to be able to use our LDR safely on the labor and delivery unit. All right, a few more things in the last couple of minutes, things you got to think about when you roll out your EMR. It takes a big team. All right, you can't do this. The IT people can't do this by themselves. You can't do it by themselves. All of these people have to be involved, including biomed, the pharmacist. I'll go through that in a minute. Legal, billing, compliance, your labor and delivery nurses. They all have to be involved in how you roll this thing out. Timing. You know, I did a literature search trying to look and see whether there's any evidence out there on how these things should be rolled out, and I couldn't find anything. Maybe it's not in the medical literature. Maybe it's someplace else. But, you know, should you do it cold turkey? All right, should you just say from one day to the next the whole system's going paperless? Should you phase it in? And if you phase it in, should it be slow versus fast? Should you do the labor and delivery unit before or after the general OR? I don't know the answer to these questions. I don't know if there's any evidence that suggests one way is better than the other. I will tell you how we did it in our labor and delivery unit, which is that we rolled it out in we have different operating room areas. We have a women's hospital, and so we have a gynecologic operating room suite that's a couple floors down from the labor and delivery unit. We have an ambulatory center. We rolled out the intraoperative EMR in these small areas first. Then we rolled it out into the C-section ORs. Then we rolled it out into labor and delivery. And we actually didn't do the general ORs until last, because we thought they were the most complicated. All right, so that's just how our institution did it. It actually worked okay to do the C-section ORs first, because it kind of got the nurses on board with what kind of documentation we needed, and it was a relatively smaller. We only have 4 C-section operating rooms. We have 32 LDRs, so it was better to roll it out in that small area first and then roll it out into the LDRs. And then again, the IT support, I think, is critical, particularly when you roll it out, okay, because there will be a lot of bugs in the first couple of weeks. And the bugs have to be fixed right away. And that means the IT person has to be standing right next to you in order to be able to see what the bug is and help you to fix it. All right, you can't do it after the fact. Okay, so a couple more things. You have to have a drug formulary, all right, in order to have an anesthesia EMR. And I will tell you that you can't, if you have any secrets from the pharmacists, they're not going to be secret anymore. What am I talking about? Well, you know, 8th percent bupivacaine is not on anybody's formulary, right? 2% lidocaine with bicarb is not on anybody's formulary, all right? So the pharmacist said, you're what? You're adding bicarb to your 2% lidocaine for every single C-section? Where's that on the package insert? All right, so you're mixing up 8% lidocaine for every single patient on the labor and delivery unit. We have a standard epidural solution, which is 16% bupivacaine plus fentanyl. Some patients break through, right? And so we would, patients who needed a more concentrated solution, we would just take 0.5% bupivacaine and squirt it into the bag, and then we had 0.11% bupivacaine. And the pharmacist said, you're doing what? So it's not a secret anymore. The good thing is now we have 2 solutions of epidural solution in our Omnicell machine. But these things have to be negotiated with the pharmacy before it appears on your medical record. All right, I think I'm running out of time here. There's a whole list of things that I wish I had that you need to think about ahead of time, including what kind of reports you want to generate, et cetera. I won't go into all of those right now. Again, one of the things that I'm disappointed about is that we don't have a very good rounding report. So we have a report that we can generate from the preoperative record, because that's what everybody else in the hospital does. The internists, everybody else can generate a report off of their notes, okay? We cannot yet generate a report off of the EMR. So I don't have a report that says that this patient was rebolused an hour ago, all right? So that's my next goal. I would like to know when the patient was rebolused. what their infusion rate is set at, et cetera, without actually going into the patient's record. All right, I would say the major problem that we are dealing with right now are the hardware connections. Remember I told you those wires that go behind the board? Well, the wires have to go into the wall first, and every time the environmental services people pull out the cart, you know, with the fetal monitor on it, to clean behind it, somehow they disconnect the wires. I'm getting very good at connecting wires, but that's the major problem right now. And then another thing that drives me completely crazy is keeping all of the hardware or the parts clean. I don't know how you guys do it, but ours are not clean. Okay, so that is the end. In case you can't read that, it says, according to the hospital's new electronic patient's record system, he's pregnant. Thank you.